Hello and welcome. My name is Robert Byrne. I'm a cardiologist working in Dublin, Ireland. Very pleased to be here at ESC in Amsterdam 2023. Delighted to be joined by a friend and colleague, Rasha Al-Lamee.
Hi, Rob.
Rasha's from London in the UK, and we're here today to discuss some interesting clinical trial data that's become available at the meeting. I mean, Rasha, there was a huge number of high-profile randomized clinical trials presented here. I lost count of the number of papers that were in the New England Journal, but I think I stopped somewhere around 8. A couple of these dealt with intravascular imaging, 2 in particular, and we're going to discuss these 2 together with a third study that was presented in the same session. So why don't we start with ILUMIEN IV?
We were all waiting for the results of this trial.
Yeah.
And in fact, this is a really hard trial to do. So I think the investigators have to really be commended for getting this trial done and getting it done over a very difficult period during the pandemic. So they recruited 2,487 patients internationally and essentially randomized patients to angiography-guided PCI versus OCT-guided PCI. Now, the patients they recruited were what they deemed to be either high-risk patients, diabetics, or high-risk lesions, and predominantly these were long lesions, but they could have been other complex lesions such as bifurcations or chronic total occlusions. And they looked at 2 major endpoints. The first was a procedural endpoint, which was minimum stent area, which we know obviously to be the biggest predictor of stent failure in our patients. And the second was the clinical endpoint, which was target vessel failure. And interestingly, what they showed, and as we might have expected, the OCT-guided arm had much larger stents at the end of the procedure. However, they didn't meet the endpoint in terms of target vessel failure. There was no difference between the 2 arms.
Yeah, interesting. I mean, I suppose in some respects disappointing because we've waited a long time for this trial and maybe we were expecting a clear result. So how do we square the circle there? They did find a significant difference in terms of minimum stent area, which is a strong predictor, you said, of adverse events during subsequent follow-up, but they didn't find a difference in terms of outcome events then over the time period of the follow-up.
So the investigators gave us some plausible possibilities for why that happened. One was that over COVID, they saw that the event rates in the trial really fell down, and that was possibly because patients weren't presenting to hospital, particularly with chest pain that might have triggered urgent revascularization events. Importantly, they did show us that during the procedure itself, the OCT arm had much lower rates of significant procedural complications. So there was some value to doing the OCT. And I think where the study for me is most interesting is the strategy that you used for OCT. And that was very much based on this kind of MLD max criteria where you would take a patient and not just perform OCT, at the point you most feel you need it in a procedure, but do it in a very systematic sequential fashion, which is pre-PCI to try and work out exactly what you're going to do in terms of strategy, mid-PCI if you're trying to work out, whether calcium modification techniques, etc., have really made a difference, and then finally at the end to look at the final OCT result. And in the angiography arm, they did a blinded OCT so that they could obviously work out this minimum stent area endpoint.
Yes.
But I think for me, the other part of the trial that was very important was that it was a blinded trial. So actually, while obviously within the cath lab, everyone knew what had happened, outside of that cath lab, both the patients and all of the subsequent medical teams and research teams had no idea whether the patient was in the OCT or the angiogram arm.
Yeah.
And that, I think, is key. And as you know, it's sort of dear to my heart to think about blinded trials in this way.
One of the things that people wondered about in advance, listen, this relatively blind adherence, blind in a different sense, but adherence to a sizing protocol, would that lead to an increase in perforations? Was there any signal in that respect?
The signal was very much that it was safer to use OCT, and actually that they reduced major procedural complications by using the OCT. So in fact, doing the imaging makes you hopefully size your balloons correctly, size your stents correctly, etc.
Yes, yeah. Well noted. I suppose the devil is often in the details, and sometimes the protocols are how the intravascular imaging is implemented and how it's specifically used to guide operators can make a big difference. So why don't we move on then? And the next trial up we had in the same session was October. Again, a trial that we've been looking forward to very much. Do you want to tell us a little bit about that trial and what you made of it?
Yeah, so the October trial, I mean, there were some similarities in terms of trial design. Smaller, 1,201 patients. And here what they did was take bifurcation lesions. They aimed to have predominantly left main lesions, but about 20% of the lesions in the end ended up left main bifurcation lesions. And they took patients and randomized them once again to OCT-guided versus angiography-guided PCI with a similar approach to pre-PCI OCT and then OCT following the stent and then rewiring of a side branch. And then again at the end to look at the final result. And here they had a MACE endpoint. And actually they showed that the MACE events were very much lower in the OCT arm than the angiogram alone arm.
Yes, and I think the important thing is, of course, when you use MACE, you have to dig down and look at the individual constituent endpoints. But here, I think we saw pretty concordant results across the individual composite of the primary endpoint.
Yeah, absolutely. The only thing I think is important to remember here is this time it was unblinded. So actually, you can always kind of allude to maybe knowing that someone was in the OCT arm might slightly change their care, or in the angiogram arm. It's hard to know really from that trial.
So I think an important trial, I think a clear result as to why there was relative underrepresentation of left main stem interventions. I mean, there's some obvious explanations, but what was your thoughts on that? Is it the reluctance of operators, OCT and left main stem, blood clearance, etc., or do you think there were other explanations?
Yeah, I mean, for me, I wouldn't ever consider doing a left main PCI now without intravascular imaging. And I do wonder whether the trial investigators, who would probably, many of them, be imaging enthusiasts, might have been reluctant to take those really complex left mains into a trial where they might potentially get an angiogram-guided approach, but it's hard to tell for sure, I guess.
Yeah, I mean, I think that's a very important consideration, a well-made point. In relation to OCT versus IVIS in the left main stem, I suppose we have more and more experience with doing OCT. Certainly, the more traditional approach is to use intravascular ultrasound in the left main stem area for a variety of reasons, but that's not a question that was addressed by October. I mean, it leads us on to the next trial in the session, then the third trial, which was the OCTIVIS trial, comparing directly to intravascular imaging modalities. So do you want to tell us a little bit about that?
Yeah, so here this was really a OCT versus IVIS trial.
Yeah.
And actually what they were looking for was non-inferiority on a MACE endpoint between the two. And indeed, that's exactly what we saw, that the two techniques were very similar in terms of their clinical endpoints. That's really important, I think. For many labs, there's the opportunity to use OCT or IVIS, and then there are some labs out there where only one is an option to you. And I guess what we have here from OCTIVIS is the ability to say, well, actually, the two are probably relatively similar. And of course, you have to consider the contrast burden to OCT, the learning curve of knowing one technique or the other. For me, I think for investigators, it's about being comfortable with at least one technique and then applying that as much as you can, particularly in these higher risk patients and lesion subsets.
We've seen a general increase in the usage of intravascular imaging over the course of the last 5 to 10 years in Europe and the United States. Historically, we lagged behind in comparison with our colleagues in Asia and East Asia. In particular, of course, there was a large number of trials already, randomized trials, looking at intravascular imaging guidance compared with angiographic guidance and showing benefit. One might observe that a lot of these were in East Asian populations. And now, after this meeting, we certainly have a broader spectrum of data available to us. I'll tell you, in the ACS guidelines, which were presented at this meeting also, and which I was pleased to co-chair together with Bora Ibanez, we discussed intravascular imaging at length. There were some concerns regarding external validity of the available randomized controlled trials and the broad generalizability of the results. But now we have more data that's available, which we knew was going to be upcoming. So what's your opinion? Where are we now with intravascular imaging?
I'm really an enthusiast for imaging. I think once you learn these techniques and you start to apply them in your clinical practice, you see that while there is obviously some upfront cost to using the catheter, you really minimize complications in the lab and hopefully improve outcomes in the long term. I really would like to see the guidelines change, and I think it's probably time to upgrade the indication for intravascular imaging, particularly in these higher risk patient and lesion subsets, which actually form the vast majority of the kind of PCI that we're doing in our labs. You know, it's pretty common to have diabetic patients or longer lesions or bifurcation lesions. I'd like to see it go to class 1A. I hope that the guideline committees will start to think about that. I think we now have a real wealth of evidence telling us that most of the trials are pointing in very, very similar directions. And I think it will hopefully improve clinical outcomes if we start to see greater adoption of these techniques worldwide.
Yes. I mean, I think the key aspect of the point you made then relates to selection of patient and lesion characteristics. One of the concerns that some would express is, you know, by having a class 1, are we saying that it has to be done in all lesion subtypes? But probably it's more in the high risk subtypes rather than all lesion subtypes.
Well, I'll tell you, in my lab, my IVIS or OCT use, but predominantly IVIS for me, because that was you know, where I've really been able to sort of develop my expertise, is somewhere around 90%. Mm-hmm. So I certainly am using it as much as possible. The only times I don't use it, if I'm honest, is if the case, as you know, in our cardiogenic shock case, you know, the cases where you're really trying to get in and out and completely revascularize as much as possible in a very, very sick patient. Okay, sometimes there's parameters that stop you being able to get out your intravascular imaging tool, but otherwise I use it in the vast majority. Having said that, I think there's a cost implication to that, there's a time implication to that. And so I think if we really want to see the kind of bang for our buck, we've got to be aiming it at probably those higher risk patients and lesions from the point of view of a guideline committee. But I think for most of our colleagues out there, especially our sort of fellows in training, they're probably learning to use it more and more in most of the PCI that they do.
Yes, yeah. No, I think so. We've seen generally increased experience across most centres. You can see if you track any of the national data, large increases in usage, which are prompted, I think, by randomised trial data that's become available. I know in terms of guideline committee discussions, there's a lot of discussion between 2A and 1, and already it was a very close run thing, and the decision was to wait and see what came from the randomised trials that are available now. They'll need to be digested. Of course, we had hoped for a positive result from ILUMIEN IV, which you alluded to as the trial with the highest quality metrics probably, and that didn't happen. We will have a meta-analysis. I think that's being revised now after the meeting to include the latest trials that are presented here. And while that won't solve all ills, because the limitations of the individual trials will continue to be represented in the meta-analysis, I think it'll probably move us a step further along.
Yeah, I mean, I think what we've got from this meeting on this occasion and with these very big publications is hopefully an iterative step and a very positive one for intravascular imaging. Also, as we discussed, some ideas on how we use it in the lab to the maximum benefit. And I think all of this is going to be additive for us as physicians and also for our patients going forward.
Yeah. Well, thank you very much, Rasha, for sharing those interesting insights. It's been a very interesting ESC 2023 here in Amsterdam, and we appreciate very much your discussion of these important trials.
Thank you, Rob.